Hello and welcome to HFMA Talk, the podcast for NHS Finance. I'm Lisa Robertson. I'm a Senior Policy Manager here at the HFMA, and I'm delighted to be joined today by Caroline Clarke, NHS England's London Regional Director, and Lizzie Smith, formerly from Health Education England and now joint NHS England London Director of Workforce Education and Training. The three of us were fortunate enough actually to visit health colleagues in the United States recently, in New York and in Chicago. And in this episode of HFMA Talk, we're looking forward to spending a little bit of time reflecting on our visits and the insights it gave us in thinking about our own health system here in the UK. With New York, Chicago and London all being metropolitan areas and a population of just under 9 million, they're a really good source of comparison. I want to start by thanking Caroline and Lizzie for joining me today, as well as a huge thank you to all the colleagues we met in the US, too many to name as part of the introduction, who are really generous with their time, sharing some fantastic examples of work that they're doing. So Caroline, Lizzie, before we kick off properly, can I just ask you to briefly introduce yourselves and kind of what you were hoping to get out of the visit before you went out there? Caroline.
Yeah, thanks. So I'm 6 weeks into a new job, which is all about trying to make London's health and care services like the best they can possibly be, and to make London the healthiest global city to get health and care in. My history in the NHS is as a CFO and then a CEO, and I know loads about hospitals, and I know less about how cities work. So I wanted to go and visit a city that was comparable, as you say, and to get some lessons from different people who ran parts of the city about what works well and what doesn't work well. So spending time with, not so much with hospital folk, actually. We spent a lot of time with people that ran what the Americans call behavioural health services. We spent time with the New York Commissioner for Health Services. We spent time with people who run bits of health and really good public health bits of health. So for me, it was really good just to get that insight about what works well and what doesn't work well, and hopefully more of that to come.
So I'm Lizzie Smith. As you know, I used to work for HEE. I was the Regional Director for the London region, and I now work as part of the NHS England London regional team doing kind of strategic workforce stuff. But as part of that, I am the NHS London Anchor Programme lead, and I got invited out to the States as a connection to that responsibility, really. I'd spent some time in New York and in Chicago, and I suppose the emphasis of my trip was very much around health as an anchor. How do health systems and health services impact positively on their local economy, their local health inequalities, and so on. And this is something that's been quite big in the States, particularly through places like Rush in Chicago and various different organisations in New York. But I think, interestingly, when we came back, a lot of the themes and so on were very similar, and the relationships and the similarities and differences between these comparable but very different systems were very striking. So it's a fantastic opportunity to go and learn and see London in a different context.
Yeah, because there's a lot to learn, isn't there, when you go and see somewhere else and take the time out of your own kind of day and step back, thinking about there's lots of differences in the way they do things, but actually there's a lot of similar challenges that they were working with in the US, I think, when we saw that. So in terms of context, the structure and funding is very different. So basically they have the privately run hospitals using an insurance-based model. So that's provided by the state for over 65 and those on low income, but predominantly it's provided by employer insurance. And a much greater proportion of their GDP is spent on health. So in 2019, it was around 10% in the UK compared to about 17%, I think, approximately in the US the same year. But actually, a lot of the stuff that we saw out there was very similar, and their context and the challenges are the same. So they're still recovering from the impact of COVID. They're facing financial sustainability issues, demand issues and workforce issues. So a lot of what we saw did resonate with the challenges that we're seeing here in the UK too. So it would be good to get into some of the detail of that, I think, and certainly some of the comparisons have been about what works, what's totally different out there and what's similar. But I guess what was, in terms of the first impressions, or when you came back, what were the first things that you were telling people about, I guess, that you took away from the visit?
I'd be interested to see what it was like in Chicago, actually. But I can remember, so I went from Washington, which, and we were staying in Washington near Capitol Hill. So it's kind of very wealthy, very leafy, felt quite, kind of, you didn't really get a sense of the inequalities in that people talk about in the American health system. And then we jumped on a train and I was with my partner and my daughter, and we turned up in New York. And literally, like, it hits you straight away when you get on the subway that like every second person is in a state of frailty, either kind of mental frailty or physical frailty, which you just don't see. So you just see people who are like much more disabled on the street, and just, you know, that thing that there isn't a welfare safety net in the same way that there is in the UK. And that really struck me and my 13-year-old. She was like, Mummy, this is very different, you know, and slightly alarming. I kind of don't know what it was like in Chicago. Do you get that same sense?
Yeah, you do. I mean, I felt that actually even slightly more in Chicago than I did in New York. Really vulnerable people on the streets. In Chicago, there was a thing going on at the point I was there where a local philanthropist had put ice fishing tents under bridges in the city for homeless people to stay warm in overnight. That just wouldn't happen here. You know, you wouldn't, the council would come and rip them down. You wouldn't get that kind of charity playing out in such an explicit way. I think one of the first things that I haven't spent a lot of time in the States actually in my life, and it sounds daft, but the thing that I kept saying to people when I came back is, it's huge. It's like many countries bolted together. They can't do command and control the way that the Department of Health and the NHS likes to. That was really striking in the anecdotes about COVID. So control is very different, and the lack of social system, exactly as you said, Caroline, and then the role of, and this is interesting from a finance perspective, I think, the role of philanthropy and charitable foundations in real work, in real policy. We're not used to that here. I think we're going to have to get used to it. But it was such a striking difference. That lack of the kind of mothership that we kind of love to hate.
No control.
They felt much more exposed in that way.
Yeah, Lisa, you and me travelled Manhattan and saw, like, you could see you could get the best healthcare in the world and no healthcare in the world. So, I mean, do you think the same?
I did, and I think that on the flip side of what you were saying about kind of the philanthropy and trying, you know, the safety net. On the other side, when we came off the plane, the first thing that hit me was the billboards and the TV adverts, and they're glossy and they're really kind of like pitched at people having money to spend on their health and come here with the best health centre for X, Y, or Z. So that was really startling to me, having not kind of ever seen that advertising for health quite so much
kind of go
the same
shopping
way.
for your chemo.
Yeah.
It's better here than it is down the road on the TV in the morning when you're having your it's just so weird.
Well, you know, we went to that primary care centre in East Brooklyn, so it's quite socioeconomically, it was quite a deprived area, and they very proudly showed us this amazing, lovely primary care centre with integrated behavioural health and primary care, and it all felt like it clicked together quite well. And then you just looked over there and said, what's that building over there? And it was like, oh, it's another primary care centre that's been set up in competition, and that's why they spend 18% of GDP on health, because there isn't a controlling mind to kind of dampen it down. I think. Well, I've reduced the argument to one thing, but you know, it's quite shocking, wasn't it?
It was really interesting, and I think the way that it's set up and how everything's integrated, that was a real example of, we've done really well here, we've built this up, and so someone else has built it next door because we've proved to them it kind of works here. Which was very strange, and we learned a lot, didn't we? I think maybe even when we went to Staten Island as an example, about kind of how integration works in one place, and that was really different. So I think we were trying to explain, because the conversations we had were really good, because I think we heard a lot about the health system in the US, but equally the conversation was very much about how it's working in the UK, in London as well. And we had some really good conversations around how that works, and we were trying to explain the NHS system, and that we're working to improve integration here, and we had the Health and Care Act and some of the changes that's brought about. And I was struck when someone said to me, Lisa, we will out-fragment you every day of the week. That was really interesting, the amount of layers they've got when they're trying to deal with integration. I don't know if that was something you saw in Chicago as well, Lizzie.
Yeah, absolutely. And actually, again, it was we met an amazing woman who worked in public health in Chicago, and it was a really interesting comparison. The guy that ran public health COVID London is a hero. The woman who ran public health in Chicago, doing the same work, trying to tackle health inequalities, trying to get kids education, trying to get people food, had police cars outside her house because she had death threats every day of the thing, you know. And there's something about the exposure to people trying to do this good work. There's a very different culture on it. So I was I was really struck. And so it's when you looked at particular examples of how things have played through them. And actually, I spent a lot of time in local politics when I was there. A lot of my connections through the anchor work in the in City Hall for these places, and I've got deputy mayor responsibilities for like health and housing. The politics is very different and very challenging for them to work with.
Yeah, that is a difference, isn't it? That often the people that you're working with actually have been elected. So in the UK, we tend to match executive to executive. So whilst I've got a relationship with the London mayor, actually it's the executive team who aren't elected who are doing the work. Whereas I think in the States that's a bit different.
Particularly in those big cities where they have urban mayors who have quite a lot of devolved accountability, much more than we do in London.
Yeah, that thing in the States that you're working often with this thing is mandated by the state versus the federal government, and they're having to, we had some quite interesting conversations about which bit of law was being observed and all that clean air stuff. So when Lisa and I were there, it was the Canadian wildfires, so it was quite smoky. And in fact, our trip to Staten Island, I thought we were going to get trapped on Staten Island for a couple of days. So, but there's a theme in all this about trust. So that example you just gave of the Chicago commissioner being kind of hounded, there was a big thing about how do you get trust, particularly in a country where there isn't a safety net particularly, but that issue is the same here. So how do we get our vaccination rates and our screening rates up? And the answer is you need to build trust. And we heard a lot from colleagues in the Montefiore system in the South Bronx, as well as the Staten Island partnerships, around their work in communities and their work in schools. And the school, I came back to London with a renewed understanding of we need to be in schools now, working with the workforce of the future, working with the patients of the future, educating them about what it is to receive health and care, and also encouraging them to come and work in the NHS, because like us, America's got big gaps in its workforce, isn't it? So do you remember when we went to I was on Staten Island, wasn't it? We went to the mental health facility and they had like a 40% vacancy rate for psychiatrists. And it was quite astonishing that they only said that in response to something we said. And it was like, oh my God, you've got the same issues as us. So but they would learn to live with it, I guess.
Yeah, I think there was a lot of stuff that they seemed to be normal for them, even kind of things like the opioid crisis. I mean, that was much starker there, and how they were trying to deal with that. It was almost like they had acute community behavioural health, as they called more what we would see as mental health, but then they also had like an opioid branch as well as its own tranche, I think. But they did talk quite a lot about the social determinants of health and what they were trying to do to tackle that together, and I thought that was quite interesting. And the schools work program, I think, picked that up quite nicely, but I felt that was a little bit different in how they were linking that into the work that they were doing and what they were developing out there. I don't know if that kind of came through to you guys.
The number of people that have been trained in public health, I don't know if that's the people that we chose to speak to, and Michael Marmot, of course, is a UCL professor, and I had him quoted at me so many, and I was like, God, we have to go across. So public health bodies listening to this podcast, yay, well done, everyone. But it did make me think, I wonder if there's more we need to do in the UK, because, of course, unless you tackle the social determinants of ill health, nothing will happen. So the Anchor programme, Lizzie, is all about the social determinants of ill health. And so did that come across in Chicago?
Very much so. So in Chicago, there's Rush. It was a great big, teaching hospital effectively in Chicago, university and hospital partnership. And they started their anchor work several years ago now, simply because as a hospital, they were completely overwhelmed with demand for their services. And the workforce couldn't keep up and the services couldn't keep up. They're also sat in a really deprived part of Chicago where they could demonstrate no relationship to that local community in terms of how they were trying to they needed to improve the health of their local health economy and their local population, and also the economic viability of that population, because otherwise as an organisation they were completely overwhelmed. And that's where really the anchor work has got itself into healthcare, to say you guys have got a presence in a place and you are of an economic kind of volume and size where you can actually turn some of these dials just because of who you are and the money that is going through your system because of you. And actually again it comes the environmental impact of a hospital, the air quality, all of the road trips, they impact negatively on the environment. It's all these type of things. So they got going with that, and that has become something that has shared itself around. But actually probably the best thing we saw in Chicago was an alliance. West Side United, I kept thinking it sounded like a football team to us, but they were this amazing alliance of organisations like health, education, but wider than that as well, police, loads of schoolwork, loads of drug and gun work. Of course, they've got drugs and guns in a way that we just can't imagine. And they had been so effective, and their single purpose of that West Side United was to reduce the gap in life expectancy from the best, from the most affluent part of Chicago to the poorest, which was something like 15 to 18 years. And we've got those life expectancy gaps in London. We've got an 18-year, I believe, at the moment, life expectancy gap from southwest London to northeast London. And they were focused on that single purpose, and they were doing, but again, they were relying a lot on charitable stuff, a lot of philanthropy, a lot of, they'd get their cap out to anyone and look for, but it was impressive stuff, and I think we can learn from it.
You said that, like, what were the things you talked to people about when you came back, and that thing of because they don't have the welfare state in the same way, people have had to forge these partnerships, and so much good work depends upon like good close relationships, and so I think there is loads to learn from that, actually.
Real collaboration.
We heard a lot about what they called peer support workers, which I think was a little bit more like social prescribing here, but certainly using people in the communities to talk to people in the communities and get them on board and try and get the access there. That they seem to talk about that quite a lot, as if that was really one way they could get into part of the system, I think, that we
and actually on that, Lisa, another striking difference was this thing about aligning incentives. So something I'm really interested in now so to use that example of working with local people, trying to solve a problem, this wasn't with the anchor stuff, this was talking to one of the large primary care providers, real problems with their mammogram rates, real problems with underdiagnosed breast cancer in certain communities. So they effectively had a system whereby the people who were hitting the phones to try and get people in got $20 when they got someone through the door. And they just matched the incentive to the problem, and that care provider got their mammogram rates up by about 400% over a period of time. And again, I can just imagine all the finance directors, I've got goose pimples on their arms now listening to this, but you come back and you think, why can't we align incentives in that way? The money we spend trying to resolve these problems in a way that is culturally the norm in health and care in this country. What about trying to incentivize those people who are trying to get people, as long as it's all done ethically, you're solving a problem. So I came back feeling like we needed to really challenge ourselves on what incentives mean. And actually in the NHS, we could probably all think of more examples of where we've got perverse incentives that incentivize the wrong behaviours than we can thinking about ones that work. And you as a recent hospital CEO must have felt that all the time.
Oh, totally. I know. I suppose the lesson now in a period of austerity, we need to be our most creative selves, don't we? So, for all the CFOs listening, like, unleash your creative juices on the problems that you face, and actually that some good stuff can come. They say, austerity breeds innovation, don't they? And, all the stuff I've read about innovation would tend to think it comes out of countries that have nothing rather than countries that are kind of quite rich. It's interesting, though, that stuff has come out of America, which is a pretty rich country. So there is innovation there somewhere. But I think some of this is innovation by necessity, because if people don't have partnerships, don't do the things that you're describing, healthcare just becomes so, like you chasing stuff that doesn't exist.
Do you remember that example, Caroline? I think it was the one you were saying about the primary care hub that we saw, where they were saying they had the primary care doctor and they had the behavioural health on the same site. So when people came in with issues that they were trying to deal with, mental health issues, rather than referring them to primary care, it was around, well, what will incentivise it? They won't go. If we send them out we let them out this building, they're not going anywhere. And so just having the same people in the same room. And I felt like that decision had come out of working out what the patient was going to do and how they were going to act, not on paper how this system would work best. It was like, okay, all around the patient. I thought that was quite interesting. What do they call it? Was it bilateral integration or something like that?
Bidirectional.
That's it, bidirectional integration.
And that's the thing, isn't it? So you need to. It requires a little bit of reinvention of primary care and the concept of primary care in this country, but to think that that actually someone with the professional training of a GP actually needs to be co-located with mental health teams, like community mental health teams and stuff, and then they refer into the GP, because you're right, they produced the GP for us at the end of the day, didn't they? Up she came we went down to her with a stethoscope on, and and because in this country it just would not. Well, I think there probably are examples of it working like that, but I think it's quite unusual. I've sort of asked a few people about it, and it's like, oh yeah, we could do that. It's kind of, I suppose the thing that's in common with both countries is there's huge variation in systems. So we saw loads different places, and and all healthcare professionals want to do the best for the patients that they see, and a lot of big populations are different, so a lot of healthcare delivery has to be variable by its very nature. But you can still have kind of fairly standard care processes and protocols for defined conditions. And I think they struggle with that as much as we do. But, the accountant in me, as well as the kind of manager in me, wants there to be more consistency about cost and quality.
Yeah.
And we didn't see so many maybe because we didn't ask for it, but digital was not always the answer to stuff there. Then you'd expect to see people leading off more with some of that tech stuff. I was quite surprised about that.
That was as variable as everything else, wasn't it? So when they were talking about the kind of the patient records, we had some really good examples. So we had a call while we were there with the New York Hospital and Housing Association, didn't we? And they were saying that they'd got the Epic patient record across all their sites launched in March 2020, and what a relief that had been, because they had such a big group of hospitals that were managing. But they'd kind of done that, and then we talked to other people that were like here still kind of on paper, and other ones trying to work out how they were going to use their data. They seem to have lots of different data sources, probably not dissimilar to here, lots of data, but turning that into information and how they use it. We saw quite a variety of examples of that, didn't we? We saw a good one. Now, was it I feel like it was in Staten Island, where we were talking to them about the data they were using, that they were actually using that to prod like the annual checkups with GPs and getting people to do all this. So we use it. We had some good examples of technology out there, but quite varied, I thought.
But I thought the Staten Island that was really interesting. They were such an interesting group of people. But there was the Health Integrator organisation, which itself was very separate. And they were responsible for kind of getting the data together. Then there was the Accountable Care Organisation, which used the data. And then there was the Staten Island Partnership, who used the data slightly differently. And I just thought that was so interesting that there are so many. And I kind of thought, well, okay, that's going to happen to us, because we're going to spend time with ICSs. We're going to spend time with acute and other provider collaboratives. They're all going to have different insights. And I've spent quite a lot of my career chasing the kind of holy grail of single source of truth, one set of data. Let's stop rowing about that. But actually, in the complex world that we live in, it's going to be impossible to just do that. I now realise. And so, but we have to. I suppose, and the other point I wanted to make actually was around information governance, that there seemed to be less of an issue there about sharing data than here. Do you think did I read that right?
Yeah, no, it definitely seemed to be less of an issue. It was more of an opt-out rather than an opt-in, wasn't it? I think the way they were describing it.
And that's ironic, isn't it? Given that actually what we've got in the NHS is an incredible richness of data that we all collectively own. Yeah. And yet we can't understand how to share it and use it. I am very much believe we've got a richness of data that we don't understand how to utilize. And whereas in some places in the States, the best data they were working off was the cause of death off a death certificate, because they don't have access to any, and yet they're doing more. In some cases, they're doing more with that than we're doing with our really sophisticated data set. So I think there is something about holding the mirror up.
Well, interestingly, when we went to, I believe it was Montefiore, we went to, one of the guys around the room explained it as he saw it as an information management business rather than a health business, didn't he? Right. And it was how you kind of put everything together, and that his role was making sure that all the dots were joined, that people had the right information they needed, and that was how you would manage health. The actual health kind of acute management or was a different part of the role, I think, and that probably lends itself was quite interesting. I thought to see
that conversation they had a GP in the room, didn't they, primary care physician, and she kind of came alive when we talked about. I could remember sort of the information for her was really critical in terms of how she managed her workload, and so you could see, and in fact there is something about, so actually the Montefiore system is really interesting, isn't it? Because they do have more of a public health population take on life and will use data in that way. They showed us some slides around, I mean, the Montefiore system, for people who don't know it, has been written up a lot in the UK, and the King's Fund did a kind of a case study, and they were particularly, the reason why I wanted to visit them was because they'd done a lot of work on kind of non-traditional areas of healthcare. I mean, they basically addressed the social determinants of health like a long time before we were even thinking about it in this country, it seems to me. But they've, so they were working in schools, they were working in housing, they were working with, community groups, and even taking over housing kind of 10 years ago and stuff, weren't they? And I think they've moved on from that more now, although their work in schools was really impressive. They had their schools leader there. And I just thought that thing about trust and relationship building and the workforce of the future and all that stuff really kind of obviously stayed with me as I keep talking about it on this podcast. That's a really big lesson for me. But they have seemed that I think they've moved a bit into now, we're a manager of information for our patients, but we're going to take all the social determinants of their health as well as health information. That was the other bit of that lesson. So they were interested in people's educational attainment as much as they were around their kind of current health status.
Yeah, definitely. And I don't know whether you saw this in Chicago, Lizzie, but I think it was really interesting where we saw them talk about the importance of information management, the importance of technology, but actually some of the best examples that made the biggest difference was, I think it's in Staten Island, they quoted us their approach was the warm handoff approach. So they'd almost were describing where there's people too reliant on technology. So, I don't need to tell the consultant that this person's coming to see them because they could see it on the patient records and they could see in that. But they said the most effective change was actually walking someone to another part of the building or putting a WhatsApp message saying so and so is coming to you. Actually, what you need to know about them is that they're terrified about needles, or what information would you need to make the life better for the patient. And I thought that was a really interesting dynamic, making the most of the people side and the technology side together, not losing one or the other was really good.
Because all the clinicians, we'll come back to Chicago, but I think all the clinicians I know tell me that everything goes wrong in the handover. So that warm handoff concept was really interesting. Sorry, Lizzie, how was it in Chicago?
I haven't really got any reflections particularly on. We didn't really get into those sorts of conversations about actually how you actually dealt with the people. But what I was thinking of when you were talking about the schools thing, there was an organisation in Chicago that just worked with young black men who were far, far more likely to get caught up, in the gun crime and things like the drug problems. And they've done a lot of work in Brixton, actually, and they're really interested in doing more work with it. It was really, really interesting. But the thing I was thinking of as you were talking was their health metrics for these young men were, first of all, were they ready for school at 5? What was their attainment at school from this year to that year? So it flowed into education, through education, and into health and into employment. So all of their health metrics were actually, were they ready for school? Did they go to school? Did they graduate high school? Did they get a job? And they were the health metrics. Because actually, do they have a house? Do they have a home? Are they fed? Did they get an education? Because they are the health metrics. And I think that's where we're headed, isn't it?
And that's exactly what we heard in Staten Island and in Montefiore Fuel Systems, I think. So
yeah, absolutely. And I feel like we could talk all day about this, and we saw some amazing examples, but I am conscious of time and that we'll have to end the conversation at some point. I'm sure if anyone bumps into any of us out and about, we would be happy to tell you more about what we saw out there. But I guess final thoughts from us before we wrap up is, are there any overriding reflections from your visit that you really think we could put into action quickly in London and wider in the UK? Anything that particularly we should kind of hold on to as we try and work through a difficult financially and operational time, really?
Well, for me, I guess a couple of things. So it really made me think about the work we're going to do in schools and the work that in my new job we might do with the Greater London Authority and the Mayor, and to put much more emphasis on that, I think. And then the second thing is probably something about how we enable really good partnerships to come together and stick and do good work, and that my job is to work to enable those partnerships and then work through them. And some of that, of course, is about good relationships. So really getting people to come and work in London, because it's the best place in the world to work, if anyone's listening. And here's every opportunity, recruitment opportunity, but then to make it a really nice place to work. So I think I came back with a bit of that. Lizzie, what about you?
Well, we haven't talked much about workforce stuff, but that's my background. And I think for me, I saw evidence of people using different roles in a way that we haven't done certainly in London, not so much in England, but certainly in London we've got a problem. The physician associate would be one where they've really made that work. They tackle their workforce shortages in a very market-driven way, turning taps on and off as they need them. We can learn from that, and I've talked a lot about that since we got back. But I'd go back to this thing about aligning the incentives around the outcomes that we need. I think we should feel a bit liberated and do some more of that alignment incentives, and actually and just keep backing the anchor stuff, because actually that's a path to a sustainable future in a lot of ways, and we need to be on that path. So there'd be the kind of three things.
Here. What about you, Lisa?
I think there was something around helping people do what they want to do. So everyone knows the right thing to do, but there are so many barriers involved in making that easy. I think there was something about that. And the other thing that I really took away from it is we went to go and learn from the US. And so in that position, we got a lot of people in the room together. And the benefit they had from talking to each other, I think, about what are we trying to tackle, how are we doing that, just face to face for an hour at a time, with no set agenda particularly. There's something to be learned by sitting down and actually saying, right, what do we need to do now? I think I took that away from it, and I was exhausted by the end of it. That was the other thing I took away from it, because we had so much information to process. It was really, really interesting, I think, from that point of view. So
but people were so generous with their time. I mean, that's the other thing. They were just absolutely lovely. I don't even know if any of them will be listening to this, but if they are, I just want to say a massive thank you again, because it was a privilege to hear some of the conversations, and a lot of those lessons I will just take with me now, and we might have to repay it. So shout out to colleagues in New York. See you in London.
I couldn't agree with that more. The working culture there was tough, really tough. People worked so hard and were so passionate, committed to what they did, and so willing to share. And I've had a lot of follow-on conversations with people from there, and I know I've got relationships I can go back to, and it was a fabulous opportunity. I can't thank them enough.
Absolutely. Too many people to thank. But what I will be doing is writing up some of the stuff from our visit as well, and there'll be lots of thank yous in there and reference to the people that we saw. So please look out for that. If you've enjoyed listening to the three of us natter on about our experience, then look out for the document as well, because we'll probably able to add a bit flesh to the bones for that as well.
And I say thank you to the HFMA. So of course our visit was made much easier by having Greater New York Hospital Association really set the context and frame it for us, and I found that really helpful on our first day. So big shout out to them.
So thank you so much for Caroline and Lizzie for joining me today, and I hope listeners found our reminiscing helpful. We will be publishing a write-up of the New York visit shortly, so keep your eye out for that on the HFMA website and in our weekly emails. And finally, thank you for listening to the HFMA Talk episode today. Don't forget to subscribe in this podcast to keep you up to date with more episodes going forward. Thanks a lot. Take care. Bye.